Good morning, everybody, and welcome to this session. Good morning, Dr. Lahane. Good morning, Amar, Dr. Kulkarni, Aditya, and Preetham, and all other participants.
Morning,
We
sir.
go on to the second session on refractive, and we have a large uh, good speakers, I think, from all over India. And I think congratulations to BOA, Maharashtra Ophthalmic Society, Dr. Lahane, Ragini, and everybody else for putting this program together. I'm sure this session is going to be a wonderful session with all the good speakers. So without any further delay, I'll just request the first speaker, that is Dr. Partha Biswas, whom we all know as the chairman of the Scientific Committee of All India Ophthalmological Society, a great individual, I would say, a great human being, and above all, somebody who has dedicated himself to the field of cataract and refractive surgery. So he's going to talk about LASIK surgery in the current COVID scenario, the dynamics of practice. Dr. Partha, all yours.
Thank you very much, sir. Are my slides visible, sir?
Yes, we can see you, sir.
Thank
Yeah,
you.
slides are seen and even you're audible.
Can start right away. I think we've exceeded the time from the previous session.
Yes.
Can you hear me? I seem to have lost the screen.
Yes.
Yes, sir. I can hear you. Can you hear me? Can everyone hear me?
I think there's a lot of sound disturbance.
Someone, if he has logged in, it would be appropriate.
Can I request the others to mute their mics, please?
Yeah, there is somebody from the admin whose voice is echoing.
Okay.
Yeah.
I think it's fine now, sir.
Yeah, perfect.
Yes.
Perfect.
So thank you very much, BOA, MOS, Lahane sir, Ragini madam, for having me in this program. It's been a wonderful first session, and now we come to the second session of refractive surgery, which again brings us to the next scenario. So in the current COVID scenario, LASIK surgery and the dynamics of practice, what is it? How is it different? In the first wave of the COVID, we had a large number of risks which we dealt with, and a lot of thought processes went in. And it was predicted that the COVID would take a very bad toll on the refractive surgery practice. But did that really happen? Well, most of us came back to our refractive surgery practice quite early than what was predicted. And this was the scenario. Today, with the COVID update, number of active cases with over 37 lakhs, and India's the second wave of pandemic is a catastrophic wave. So with these things in mind, do we still have the refractive surgery, and how do we practice it? So the AIOS came up with the preferred practice patterns of the refractive surgery during the COVID pandemic, and we had a lot of learning from this. Today, the most important question is it safe to do refractive surgery? Is it safe to do LASIK? And how do we keep afloat in the LASIK practice? Again, should it be performed during the pandemic, and what precautions do we take? So this was included as a non-urgent category of ophthalmic procedures per guidelines published by the IGO, and most surgeons were reluctant to perform during the lockdown. We witnessed there was a normalcy over the last 6 months, no new guidelines for the second wave we have as yet. But there has been a lot of learning from the first wave and what we have done, performed, and the values that we could edit in the LASIK practices. So is it safe to continue with elective procedures? What risk does the refractive surgery hold today in the second wave? And is LASIK an aerosol generating procedure capable of transmitting COVID? Can it transmit live virus? The answer is in the 1997 study. And this was a study in which it so said that the excimer laser ablation plume does not appear capable of transmitting live virus, and this was done on the HIV virus. So the virus attaches itself to the ACE2 receptors and the corneal epithelium. The cornea, conjunctiva, and are the possible sources of infection for the SARS-CoV-2 virus. It may be present in the tear film and in the aqueous humor. So what do we take as the general measures? So let's go on to the points. The staggered appointments, very important. History of any symptoms of COVID, temperature by non-contact, social distancing norms to be strictly followed in the areas of reception, pharmacy, waiting areas. Let us remember once again that this is a procedure that might be aerosol generating, and the transmission of COVID today is mostly through the transmission through uh, the particles in the air. So all patients and attendees and the staff to fill in the COVID declaration form, doors and windows to be kept open in the waiting room as much as possible, surfaces to be cleaned periodically. The pre-operative guidelines. So the examiner should wear gloves, protective glasses, protective gowns, change of gloves between each patient while performing refraction, avoiding touching of the forehead, the trial frame, the pinhole occluder, and all lenses to be cleaned between patients. Breath shields for slit lamps as barriers for the patient and the examiner to be used all the time. Measurement of IOP using the Goldman applanation, and the prism to be wiped with alcohol between the cases. Corneal topography is a quick, non-aerosol generating procedure and non-contact. So the intraoperative guidelines let us adhere to. We might have slacked down on these guidelines in between the first wave and the second wave. Let us reinstate. The use of N95 mask, the triple layered mask, or the surgical scrubs, caps, the sterile gloves, and protective goggles are important along with the disposable gown, both for the surgeon and the assistant. The COVID-19 consent form for the surgery to be duly signed. And here we see the flow of the patient as the patient comes in, both the patient and the attendant who have to be in particular social distancing, and they have to have the firm protocols very much in place. So the patient comes in, the taping of the nose is important, and the patient should be wearing the disposable gowns, as well as the attendants should be wearing disposable gowns. The ocular surface wash with 0.25% povidone iodine 10 minutes prior to the surgery. And let us remember, this povidone iodine has to be removed with well amounted irrigation before the LASIK procedure. The patient well draped under aseptic preparation. The eye drape pouch. The eye drape pouch is important and has to have the 10 ml of 5% povidone iodine solution, which ensures the sterilization of the solution used to wash the stromal bed for any secretions from the ocular surface which might get washed into the pouch. Also, it protects the healthcare workers and involved in the disposal of drapes, minimal instruments to be used on the surgical trolley, and the drying of the ocular surface thoroughly by sterile dry swab before starting the surgical procedure to avoid any pooling of the secretion. And this could be a potential source of aerosol and should be avoided at all instances. The monitor for the visualization of the flap creation instead of looking through the microscope, and use of the monitor while the excimer laser is firing to avoid exposure to aerosols. And while washing the bed, the practice of simultaneous drying of the ocular surface with other hand using a sterile metal swab to avoid pooling of the solution. So this is the flow that we have. And immediately post-usage, immerse the instruments and disinfect them in solutions of lysoform and other solutions. At the conclusion of the surgery, using of sanitizers to disinfect the gloves. These scrub after every case. If a disposable gown is being used, should be discarded after every case. Ensure change of sheets and cleaning of the patient while disinfecting of a holding time of 15 minutes. The surrounding floor also should be wiped and allowed to dry. Microcatome assisted flap creation has a little more aerosol dispersion as compared to the femtosecond laser, and this is also important and has to be taken care of. Post-operative guidelines, these are routine instructions and medications that can be given. Early tapering of steroids if they are used, the IOP measurement if needed, using the Goldman stonometer, and consider keeping the post-operative follow-up visits minimal. And here is the importance of video consultation for any post-surgical problems, which may be minor, but of course to be seen if the patient has major complaints. So to conclude, the pandemic is here to stay. Refractive surgery, let's just continue. Till date, no evidence of spread following refractive surgery, but diligence and all precautions to be taken. Thank you very much for your patient hearing.
Thank you very much, Dr. Partha. Any comments from any of the co-chairman, convener? Well, the studies that have been done essentially, as Dr. Partha has said, there has not been any significant report of transmission specifically after laser vision correction. And the povidone iodine, which is being, which Dr. Partha has rightly said that if at all there are any virus particles in the tear film, it really takes care of that. But one of the observations that at least we are seeing that the number of patients with conjunctivitis in the second wave is much more than what we had in the first wave. I don't know whether it's seen by other people or not, but there are a lot of patients who are COVID positive. Actually, there are 2 patients who first came with conjunctivitis, and I told them to get the COVID test done, and they turned out to be COVID positive. So the number of cases with conjunctivitis with COVID are at least maybe the numbers overall are more or what, but at least I am seeing, or we are seeing, more cases of conjunctivitis. I don't know if anybody has any similar observations.
So quite true, sir. Quite true.
Huh?
Yes, yes.
I think this is quite true. And also we've seen 2 cases of post-COVID vaccination conjunctivitis. So I don't know how many people have seen that, but it is quite true that conjunctivitis has increased more in the second wave than as compared to the first one.
So I think that is obviously it is the povidone iodine is something very good, and then there is no aerosol generation in such specific procedures. For example, in the smile procedure, there is no aerosol generation which is there. So I think that also is something that one needs to take care of. But whatever Partha has shown as the precautions, they are pretty apt, and if taken, I don't think there will be any great chances of transmission. Dr. Lahane or anybody wants to say anything? Dr.
Yes, Maipal sir, what you are saying about the conjunctivitis is true. But in Maharashtra or in Gujarat, if you can say, we are also getting the mucar mycosis in a big number. So that is there, and even the in such situations, exenteration is also burden in few cases. So I think the ophthalmological involvement is more in the second wave.
Yes, sir. That obviously is because of the immunosuppression that is there, that the cases of mucor, orbital mucor, etc. have significantly gone off. And we have also reported from Delhi 6 cases of late post-operative fungal endophthalmitis, endogenous fungal endophthalmitis. So overall, those are the things which definitely are there because of the use of the steroids and the toxin. That is all are immunosuppressants. So there's these cases, the black fungus as it is called, is definitely on the increase. As also endophthalmitis in 6 cases we have reported. I don't know whether anybody else has seen or not, but recalcitrant inflammation which is there in the posterior segment, I think we need to rule out, and in those cases we have been able to find the fungal endophthalmitis. I don't know, Preetham is here, maybe.
No, we have seen endogenous endophthalmitis on at least about 5 to 6 cases, and these have been typically cases which have had hospitalization, hospital stay for more than a week or 10 days. So these are inpatients probably which have been kept on steroids, and been given even some immunosuppressives these are the ones probably who are developing these sequelae.
Yes. In case there is no other comment, then we can go on to the next speaker. I think Amar, everybody knows he is somebody who's always done India proud and has come out with, I think he's one of the sharpest minds in ophthalmology, and he thinks through a lot of things and comes out with every other year or every year with something new, which puts a mark in world ophthalmology, and rightly so. He has always been recognized in the top ophthalmologist, the power list of 100 in the world. So Amar will be talking about his Kapadia can, yeah, thanks. So he'll be talking about his new love, I would say, his new passion, which he is doing great wonders, and that is on pinhole pupilloplasty. So over to you, Amar.
Thank you very much, Mahipal. I'll just start sharing the screen first. And let me know if the video is coming on. What happened to my video? One second.
Good morning. Till Amar sir is starting, I want to just inform everybody that we have around more than 3,000 logins as of today morning for the program.
Madam, and our registrations are about to reach 5,000.
Great. Yeah, Amar,
are you seeing the video now?
Yeah, we are.
Yes.
You can start now.
So let
Make
me
it
just
full
see.
screen.
I'm wondering why is it not going? Yeah, now it's gone full screen. Now you're seeing it?
You can play it now.
Okay, fine. Thank you.
Thank you.
So basically, first of all, before I start, my idea is to first of all congratulate Ragini and Lahane, Professor Lahane, and the entire team there, Preetham, Quresh, for doing such a great job. Now let's move on to this topic for BOA and MOA, which I've done, is pinhole pupilloplasty. The question is, when we started pinhole pupilloplasty, we were making everybody at 1.5 to 2 millimeters. And I first spoke this a little bit in Namrata's conference. Now I've taken it to a slightly next thing to make it more accurate. This particular patient, let's understand, came to us from Singapore. Now the patient had a cataract done, PK done, and if you notice, we had done a pinhole pupil with the cataract surgery. But notice carefully here, post-operatively, the Purkinje image was not centered. The patient has a 13-diopter astigmatism, but with that, if you notice now in this picture here, look at the Purkinje image. It is not centered. It should have been centered, whereas here the pupil is absolutely decentered. Basic mistake is mine. So the first thing to make pinhole pupilloplasty more accurate, remember one thing: when you make the pupil, please focus on the Purkinje image P1, because your pupil has to be on it. Now, once we have done that, in this case, there was a refractive surprise also. So now the problem which we had was to correct the pupil correction. On top of that, to do an IOL exchange through the pinhole pupil. Now we can see we are cutting off the sutures there. Once I'm cutting off the sutures there, from the side, somebody is holding with an endo illuminator so that I can see better. Now the next step is to take this IOL out. Now I was not sure whether we can get a PCR or not in this case. So just to be on the safe side, we also prepared scleral flaps, though we didn't make it enter into it, but just kept it ready so that if there is a rupture or a rent, we can always do a glued IOL. But luckily for us, it did not happen. So now we have removed the IOL. Look, the capsule is intact. Now we put the correct IOL in place. Now, once we put the correct IOL in place, again, we have to redo the pinhole pupil. So now you can see the IOL gone inside. Now I have to make the pupil correct. Now remember, this technique is the single pass 4-throw pupilloplasty. It's a very simple procedure which anyone can do. The idea is again simple, making the pupil smaller and smaller till the Purkinje image becomes centered on the pupil. And you can see if you have made it too small, you can put fluid into the eye, chew it up with a vitrectomy so that the pupil comes bang on track. Now look at the Purkinje image. Compared to the previous image, the patient is absolutely correct. There's a small mistake, and another mistake which I did here is the pupil is a bit large. It's 3.5 millimeters. The patient, from counting fingers in the first surgery, improved to 660. But look, Purkinje image is centered, but pupil is large. Now, what I'm going to show you is how do you make your patients happy to create that extreme wow factor. So what I did was, I knew when we started pinhole pupillasty, we will be in trouble because my optics you need to be really solid in. So I contacted a person whom we worked with, is Jack Holliday. And we designed this instrument, which is the Holliday pinhole device. Now what we do in this is, pre-operatively, whenever you have a patient, there are many holes as you can see in this pinhole device. All you do is put it in front of the patient's eye, ask him to rotate or her to rotate. See which one she's happy with. Previously, I used to think that everybody will be happy with a 2 millimeters or a 1.5 millimeters. It is not so. Some patients might be happy with a 1 millimeter pupil. So in this particular case, when I did this pre-operatively, I found the patient very happy with a 1 millimeter pupil. So now I knew from 3.5, I have to make my pupil 1 millimeter. Now, take the patient inside. Now, question comes, how do you check intraoperatively the patient will have a 1 millimeter pupil? Remember one thing, whatever pupil you are checking outside is on the corneal level. That will be slightly lesser than the one on the internal level, which is internal will be a slightly lesser, smaller. So this is the apparent pupil. You can use the same pinhole device, and we're trying to make it better soon. Perhaps the next conference I'll make it better even for you. This is an autoclavable device, by the way. You can use this to check whether the pupil size is correct or not. Now take it even better. You have these Zeiss microscopes. These eyepieces can be removed. Once you remove them, you can put another one which has got a reticule inside. These reticule comes with the markers like this. And the simple thing is, if you keep your magnification at 1 millimeter in the microscope of, say, Zeiss, that circle which you are seeing is 5 millimeters. And this reticule, you can see the marks there. You will notice each small mark and big mark is there. The small mark and big mark together will become 0.5 millimeters. In other words, I can go up to accuracy of 0.25 millimeters. Now that you have understood this, what we are doing basically now is, I'm going to make this pupil from 3.5 to smaller. And then I want to know, because I've already checked pre-operatively, this patient needs a 1 millimeter pupil. Now, intraoperatively, I want to know how am I going to be bang on track is using either the Holliday device or using the reticule. Now, to do the single pass photoretinoplasty, see what you're doing. Everybody now knows this technique by now. Simple way is passing the suture from one end to the other, tying it down like this. Remember, you need a paracentesis only on one side. You don't need on both sides, because the loop is going to come out only on one side. From the other side, you just go through the clear cornea. Now you can see 4 passes being passed into the eye there. Once the 4 things are done, the pupil is becoming smaller and smaller. Now, once you have made it absolutely small, it might become too small, as you are seeing right now. In this case, you will need a vitrectomy probe. So keep it in mind, keep a vitrectomy probe so that you can enlarge the pupil a little bit depending on your size. So when I said you want to make your pinhole pupil accurate, one is the Purkinje image. Look at the Purkinje image, it's bang on center. Second is you are going to check pre-operatively what pupil the patient wants and likes. And third, intraoperatively, either you use the reticule. It's a bit tough because the reticule we will see only through one eye, so you can use it at the end, or you can use the same pinhole device, autoclave, so that the same thing can be used in your OT and check whether you are bang on track to 1 millimeter pupil. And you can see now I'm bang on track there. And if you go around that Purkinje image, you will get approximately 1 millimeter pupil. So this is the way you can improve your surgical results in pinhole pupillasty. Now let's see how this patient behaved. Remember, this patient came to me from Singapore. This is post-operative day 3, And imagine how many times I've operated on him. I should be really a glutton for punishment. But if you see the picture on the left, this is the first thing which you saw. Patient is got a decentered pupil. My Perkins image was messed up. Patient came to 1 meter counting fingers. We took out the IOL exchange because the patient needed an IOL exchange. Bang centered the pupil on the Perkins image, but the pupil was too large, 3.5, vision improved to 660. Check the patient on the pinhole device and you look at the picture on the right, which is the end picture. Patient's vision improved to 612 and we made the patient very good with a 1 millimeter pupil. So basically what I thought today to cover with you people is on how I can make this particular pinhole pupillasty more accurate, and we thought this is the simple way to do that. Now I'll just thing is to show you is we have also brought this out in various books of ours, as you can see here, which is Mastering Iris Repair, which we have published by Slack, which not only covers pinhole pupillasty, covers fourth row pupillasty, but covers many topics for iris repair, because today iris repair can also be a refractive iris repair. So I'd like to once again thank Professor Ragini, Lahane, Maipal, Partha, and all of you for asking me to come into this session of BOA. Thank you very much.
Amar, it is not asking you to come in BOA. You are part and parcel of BOA and MOS.
Thank you, sir.
Thank you, Amar. Thank you. Yes, Maipal, go ahead.
Thank you very much, Amar. Any comments, Dr. Kulkarni or Kelkar or Preetham?
No, basically, you are always amazed at whatever he continues to think and show it to us. So it's really nice to have Amar showing us something new every time. Thanks a lot for that. No other comments.
Well, Amar, basically, I just want to ask you a couple of things. So what you have actually highlighted is the centration and pre-operative evaluation as to what the patient likes. How good is the pinhole that you put before the patient in the OPD? Like, does it actually translate in reality to that particular thing?
From what I've started doing, before I used to make everybody at 1.5 to 2 millimeters approximately. And I tell you what, frankly, the patients were happy. But then, you know, they're very happy. There's no doubt about it. But then when I started seeing, can I take this game to the next level? And then I found that with this, I am definitely making them much better off. The question is to get that pinhole correct. So one is the pre-operative is very easy. The question is intraoperative to get it exactly correct. I feel reticule is the answer, but I'm trying to make it more simple with the pinhole device, so that you can just put it on the cornea and you'll be on track.
Okay. And as you have shown for the audience who is listening, you have shown several cases where irregular astigmatism, this could be possibly the treatment of choice, right?
Yes. Because I tell you what, Maipal, the point here is this. When you do corneal surgery, remember, it is complicated. Here, when you take a case like this, it's like your IOL surgery. Same day by evening, if I'm doing a case like this, you know, the people will just jump because they'll see immediately clearly. It's like an IOL surgery because you're not touching the cornea. Cornea surgery, whatever said and done, you know, it has its own problems when you have high astigmatism of this crazy levels like. Whereas when you're talking on the pupil or iris level, it's easy. And look at the cost. One more thing I want to tell everyone, it's just a suture. If you take a pinhole IOL against versus a pinhole pupillasty, remember one more thing. A pinhole IOL, I'm realizing more and more, is got a fixed diameter. One, it's not available, doesn't have FDA approval, that's one problem. But it's got a fixed diameter of 1.5 to 2 millimeters. Another problem in a pinhole IOL is when you put it inside, if the patient has a Uret Zavalia or something like that with a closed angle glaucoma, that cannot get solved. Whereas in a pinhole pupillasty, all these other problems also get solved because you brought the pupil down, so the angles which are closed becomes open angle.
Any thoughts on a corneal approach? If you can put a pinhole, an internal like the AcuFocus, etc., that was being put earlier into a stromal bed?
It's a very good question. And, you know, to be honest to you, Maipal, the first inlay, I'm not told officially, but was done by me when they flew down from America. And the patients were very good, the first two cases which we did. But I said, I'll not do that because I tell you again, the problem with these corneal inlays are once you're going into the cornea, the whole game changes. When you work at the pupillary level, you're very safe. What is the surgical skill required for a pinhole pupillasty? Let's give an example. If you know how to do fourth row pupillasty, the whole game changes because it's so simple. All you need is a Prolene suture 9010 And it's very simple. With Maipal's technique of using the scaffold technique for phakic eyes, I make them pseudophakic, but with that scaffold technique of Maipal's, you might be able to do it even in phakic eyes, because that's one bugbear in pinhole pupillasties. You are going to make the patients pseudophakic. But the other side is, if a patient is -10, let's say in high keratoconus or something like that, even that is neutralized by making them pseudophakic.
Okay. In case there are no questions.
One thing I would like to just add, Maipal, before we move to the next topic is, people who are doing penetrating keratoplasties in pseudophakic eyes, at least in Agarwal, I tell my team here, please do a pinhole pupillasty, because however good a surgeon is, you do not know whether these guys are going to go in for astigmatism or not. And you will see that wow factor immediately when the patient has a post-PK done, because the astigmatism is anyway gone.
Okay, great. Shall I, Dr. Lahane?
Go ahead, sir. Go ahead.
Okay. Well, thank you very much again. Once again, I've, as Dr. Lahane said, it's always a pleasure, and I feel that I am part of.
1 minute. I have not introduced you.
That's what I said.
Sorry. I invite Dr. Maipal Sajeev, my best friend, and really doing a wonderful work. I think Center of Sight is also doing wonderful work, and excellent president for the All India Ophthalmic Society, doing excellent refractive and cataract surgery. So I now request Maipal to present his topic, management of complications of refractive surgery. Dr. Maipal.
Thank you very much, Dr. Lahane.
Another thing is he's honored Padma Shri also, that I have forgotten. Maipal, go ahead.
Thank you very much, Dr. Lahane. Always a pleasure and a fantastic job as always, Dr. Lahane, Ragini, Preetham, everybody else in BOA. I'll be talking about complications of laser refractive surgery. As was discussed in the earlier session, there are the laser vision correction, and there is the PRK, etc., that is being done, and then there is the SMILE procedure that is being done. So we are looking at the complications which could be refractive, which I'm not going to be talking in detail because I'm making this more of a video based, and refractive could be under overcorrection. There could be central islands which are very rare, or induced astigmatism. There could be decentration. Nowadays with tracking and with the iris registration, this problem has been taken care of. There could be in the flap, that is what I'm going to talk. So these are a couple of things that can happen with the flap. So I'll just show a couple of videos. Now, when we are looking at the first thing, which is PRK, which is the excimer laser ablation, this is what was being done in PRK. Obviously, what Gaurav in the previous session talked about is post-operative pain, and that non-steroidal anti-inflammatories, etc., are being done. Epithelialization could be a problem, and there have been cases of corneal infection, etc., that have been reported when contact lenses are being put in some individuals. However, in our practice, we do put contact lenses post surface ablation in all cases. Also, there was a problem which is the haze problem, which is correlating with the ablation depth, the ablation zone if it is very small, use of oral contraceptives, viral infections which have been there, and ocular surface disorders, and MMC has really come, that is there. Now let us come to certain complications. These are few videos which have been collected over the years, and apologize because some of them will be pretty old. These are the complications that are there related to the flap in LASIK surgery. Now you can see in this particular case, it is a normal cornea. We are marking the cornea. I'm not using ink, but still there is a mark that is there. And this is a new keratome that had come to me, and you can see that it goes pretty well. But just watch here, there is something which is wrong in this particular thing. So you have to be very careful when you are taking out the keratome, because if you do it with a jerk, you could actually have a problem of missing the lenticule, the flap. So in this case, this is a full free flap that has happened, and you can see that this is something that can happen without any reason. The cornea was of normal keratometry. There was no specific reason as to why one should have had this. And what you have to do is that you have to see that the flap does not get displaced or thrown away. That has happened pretty often. And what you have to do is to just put the flap back from where it is and try to match the areas where we had put the mark. Ideally, you can see this, the mark is coming into play here, and we are trying to have this, but as we dry up the flap, there is something odd that is happening. And what is happening is that you can see a granularity onto the surface. And what this means is that you have actually put the flap upside down, the free cap actually that has happened. And therefore we have to reverse this. And now once we have reversed this particular thing, we will try to map the areas where there is the depression that we had. So you can see that the depression, and then you wash it. The only thing in these particular cases is that if it is a clear flap that has happened, there is no ragged edges, there is no thinness problem at different places, and it is not the thickness of the flap is pretty good. So you can actually go ahead and put the flap for paucity of time. I'll just see this mark here, and we are matching the mark. We will wait for 2 minutes in this particular case. I'm just aligning it, and then at the end of the procedure, we can put in a contact lens. As you can see that we are putting in a contact lens, and the patient will do pretty well. But you have to be very sure that the flap sticks back, and make the patient move the eye couple of times and see that there is no movement. Make the patient sit out for about an hour, and then you can have the patient go, and you can see that post-operatively there is hardly anything that is there, because it's only the hinge that has gone, and you will get a good adhesion in this particular case. But if the flap is very ragged, if it is what I'll just show you in the next case, you can see in this particular case there is a flap which patient which came to me was referred to me by another surgeon, that the similar thing that I have shown you was attempted by this surgeon. But in this case, when I went ahead and you can see that I'm lifting the contact lens, the flap is obviously not adherent. And what is the reason? You can see that the flap is actually a biplanar flap. You can see that this depth is different from this depth. And when we place this back, you can see that this is at a different depth and this is at a different depth. So basically what has possibly happened is that the keratome was being moved, and the keratome got stuck or stopped or for whatever reason, and the surgeon took back the keratome and then again tried to cut at that particular point again. So therefore, there are two depths at which the keratome has moved, and you got a biplanar flap. So in this particular case, we are trying to have removed the extra part of the stroma which was there. And we can just show you that we are trying in this case, because the flap was of different thickness. So we are trying to put sutures and keep the flap in position, because this flap is not going to remain in position. The patient came to me 72 hours after the first surgery, and there is obviously swelling. So at the end of it, we feel that the process is good and the flap should stick, and this is what it is. But when you see, there is a stromal melt that happens, and at 3 weeks the flap melted. So we just went ahead, and cornea being very, very forgiving, the flap was sacrificed. And the patient is actually, this is few years old, the patient is doing pretty well. The cornea being very forgiving, and the patient has gone to US and is doing reasonably well at a 6/9 vision. So all that I'm trying to say is that not all free flaps can be put back. At times you will just be doing good by putting a contact lens if the flap is regular. If the flap is irregular, you might try to put sutures, and despite sutures, you may not be able to have the flap retained. And if you do not have the flap retained, there is no harm in sacrificing the flap. Now, there are two things that can also happen as regards the complications. There is two things. One is a CTK and a DLK. So DLK is a diffuse lamellar keratitis, and CTK is a central toxic keratopathy. Both of them can look similar, but the CTK comes normally 3 to 9 days, and it is central and involves the deep stroma. It is non-inflammatory and thought to be basically residue. Sometimes if people are using formalin chambers or things like that, which is, and it can be preceded by DLK, and both of them, because of the stromal melt, have a hyperopic shift. So whenever you have a DLK or a CTK, at times it may be very difficult. The simple thing is that whenever you have this severity, you have to lift up the flap. As you can see, it's very easy to lift up the flap, and this entire area, wherever there is the inflammatory products which are there and whatever is causing this toxic reaction, very often one does not know what is the reason why you get CTK or DLK. You will have to wash it very well, and you could use an antibiotic within that particular thing, and wash pretty well, which is there. So this is something very, very important, that the undersurface as also the stromal bed needs to be washed, and this is the earlier it is done, the better it is. And you can see this is the undersurface, which is very, very important for you to remove the entire toxic debris, and then you can put back the flap. And once the flap is back, you can see, and you will have to give steroids over a long-term period. And the hyperopic shift takes a pretty long time for it to actually go back. But it does tend to go back. What is very, very important is that the earlier you intervene, the better it is. Now, let me come to 2-3 complications which can be seen with the femtosecond. So in this particular case, you can see that we are running with the, this is the intralase which we used to use a couple of years ago. And you can see that the intralase is going pretty well. But just watch here, you can see this breakthrough. So it's a vertical breakthrough that has happened. There is a corneal opacity which is there, and that is why the cut has not been coming very well. So in case the plane is not good, you can see, can you see this tongue-shaped issue there, where there was a breakthrough? And since it is in the periphery, I'm going very cautiously and lifting up the flap to the extent which one can. But there will be, as you can see, let me just go fast forward. You can see here, this is the tongue-shaped non-cut area, which is there where you saw the burp, but then this is outside the visual axis. So we can go ahead and do the laser vision correction. And we'll just we'll put back the whole thing. It will be stable. The only thing is post-operatively, you have to look for any epithelial ingrowth, because this may not be cut. This has not been cut very well, and you would prefer to see that the whole thing is good, and you can put a contact lens, as you can see in this particular case, and get a good post-operative result. Now, whenever there are any interface debris which are there, you can see in this particular case, the cilia of a patient has come. And sorry, I'll just, you can see that the cilia is there. And when you are making a flap or a femtosecond pass, the cilia is going to obstruct, and you are not going to get, it will be a cold area, it will be an uncut area. And as you will see here, there will be problems and difficulty in separating the flap at this particular time. So whenever there are these, any interface debris which are there, which are of significance, please see this. So there is an uncut area, and you are getting a problem in the flap. But with careful dissection, one is able to lift the flap. You can see that this is a small hole or a defect which is there in the flap, but this is where the lash was, and you can go ahead and complete the procedure. Sometimes you can see from the collaterals, you can see that when you are doing a femtolaser procedure, especially in hyperopic eyes which are there, or if you are making, that means that the eye is small, plus you are making a larger flap, then under those circumstances, you can have air entering into the anterior chamber. Just to show you, this happens infrequently, but it does happen. And it really does not, you can see this, it really does not. So you will have to put the tracker off, or you will have to wait for some time. It takes a couple of hours for the air to go, or maybe you can call the patient next day and then do the laser. But just by simply putting the tracker off, because tracking will be a problem with this air, and you can go ahead and complete the procedure. This is a case which has been neglected, which is a case of epithelial ingrowth. You can see that there is a track here. You should never wait for the epithelial ingrowth to increase this much, because this causes the stromal melt, and you will have to relift the flap, as you can see in this particular case. And once you have relifted the flap, you will have to remove the epithelium from all the surface below and on the undersurface. You can use alcohol also to kind of kill. Fluorescein stain can be used to see as to where exactly the epithelium is, and you have to be very, you can see that there is a stromal melt here. The epithelium has to be taken care, and you can see that if there is a railroading in from where the epithelium is growing, you can put one suture there. You must put, you can put glue at the edges, because the epithelium will tend to regrow, and put a bandage contact lens. This is, you can see that we have removed the epithelium and also put alcohol in this case, and then have something good, some good outcome. Now, this is a patient, I think this will be my last video. I think Dr. Chitra or Namrata may cover the smile. I do have videos in case they are, that's fine. This is a patient, 35-year-old female, LASIK done in June 2009 elsewhere. So this is 12 years old, developed flap folds. Flap reposition was done in August 2009. And then patient came to us in October complaining still of poor vision, photophobia and glare, etc. BCVA was this. So whenever you have flap folds or stria, the best thing is to dilate the pupil and look on retroillumination, because that is the only time when you will be able to make out as to how debilitating these stria are. And you can see in this particular case, so we are doing it in the microscope, which is the OT microscope, and not here. And the important thing here is, because this is reasonably very old, you can see that this patient came to us 4-5 months after the procedure, and look at the macro folds that are there. You have to remove the anchorage of the epithelium. Till you remove the anchorage of the epithelium, there is going to be a problem, because you have to then swell up the cornea with distilled water or hypotonic saline, and you have to keep on using two sponges perpendicularly. You can see this, and try to flatten it out. You can also use heat to the extent of about 45-50 degrees to try to iron out these. But the important thing is that till such time that you have not removed the epithelium, you have not been very patient to swell the cornea, these folds will never disappear on the table. So don't worry, they will not. But if you have swollen up the cornea, you have done enough the ironing that you need to do, and the epithelium is gone. The next day results after the epithelium heals. This is after 4, 5, 6 days or 1 week, whatever, the patient regained good vision and all the problems of the patient have gone. The other important thing is that whenever you are using a microkeratome or a femto, it is much easier to relift a flap. Whenever you are relifting a flap, please be careful of epithelial ingrowth. A fresh cut always gives you less ingrowth than a relift. But the problem in a fresh cut is that you can have a lamellar cut, and that could be a problem. You can see in femto, the adhesion is slightly more, but you can still go ahead and relift the flap. But I'm telling you, what is very, very important is that the incidence of epithelial ingrowth is significantly higher. You could also do a surface ablation on these particular cases if you want. I think I will just not show these because of paucity of time, but you can have suction loss, etc. in smile, which you can have. You can have fragmentation, you can have side cut extension, you can have with smile. You can very rarely have epithelial ingrowth, which you can see can be taken care of. We have also reported ectasia, which is something very, very important. You can have post LASIK, but unilateral corneal ectasia with small incision lenticule extraction with normal topography has also been reported. And this is reported out of eye foundation, which is the inflammatory response which you can get post smile, which resolved on steroid therapy for a long time. So friends, all that I'll wish to say that infective keratitis, this is also from our center, where we had a case of fungal keratitis after small incision lenticule extraction. And this patient, the infection, we did the wash in the interface, because you have to go ahead and go into the interface, and the patient did resolve. Post-operative glare could be there, which you have to go back and treat. So finally, what I will say is that when you are doing laser vision correction or laser refractive surgery, what is very, very important is that you have to really try to be as gentle on the eye and not cause complications, because normally these patients are normal-eyed. They are having just a refractive error. And whenever you are looking for a surgery, which is a surgery which has the refractive effect only, it is not a therapeutic surgery which is there. We have to look at perfection, and we have to chase perfection. Then only we can have excellence. That is something which is very, very important, so that the patient only goes back happy. The satisfaction rate of the patient needs to be very, very good, and we have to be careful of what complications can happen. But above all, you should be able to handle these complications if they happen. And normally, if you are able to handle them well, the outcomes are pretty good. Thank you very much for your kind attention.
excellent.
Thank you, Maipal. Thank you very much. I think always like excellent presentation and really useful, Maipal. Anyone want to ask any question?
So a quick small comment, excellent set of presentations, sir. Wonderful cases over so many years and so much of learning for every one of us, the youngsters as well as us as also. One comment that I would like to make on the CTK, sir, you very aptly said the CTK and the DLK, they need to be understood in separate entities, but again with merging significance of symptoms. However, the symptoms, if it is a mild DLK, we might wait a little and there is usually a regression, and especially if the visual axis in DLK is not the one that is affected. Therefore, the patient is not too aggrieved and is still seeing well while the DLK is receding. However, in the CTK, it's quite mandatory to do a wash quite early so that it resolves soon, because the patient's hyperopic symptoms are quite disconcerting and patient would be very, very unhappy. And CTK takes much longer to resolve in its normal course than the DLK.
You are absolutely right. Whenever you are having a DLK, it's also called as Sands of Sahara, and it depends on the grading. So if you are having grade 1, grade 2, you can actually pump up these steroids and the things will settle down. And normally they tend to settle down. And if they're fine discrete spots, you really don't mind leaving them and they will go. But as they are coalescing in the center, that's what I tried. In CTK, it's basically mostly central. And when in DLK, it goes to grade 3, grade 4, and it is coalescing to the center, that's the time when the stromal melt happens. So you do not want to have the stromal melt happen. If it is grade 1, grade 2, you are absolutely right that the steroids have to be pumped up and the thing will settle down over time, and the patient does not even actually complain much. There is some granularity in the vision that the patient does complain. The second important thing is that you have to differentiate it from an infective because you could have some sort of a diffuse picture that you can get rarely that you can get an infection. Actually, if you have something like a pseudomonas, that can also mimic and the steroids will worsen it. So that is there the eye will be angry. Typically, when you are looking at a DLK, the eye is not angry. That is something very, very important, and the vision is not this thing. So you have to differentiate infective, DLK and CTK, and depending upon the stage where it is, you will have to intervene accordingly. A very pertinent point that you have raised up.
Thank you. Thank you, Maipal sir. I think now we will go to the next speaker, none other than our secretary, my sister, Namrata Sharma, who is a secretary of the AIOS, the most powerful woman of India, my world, and doing the keratorefractive surgery. In 100 women, in 100, I'm telling in 100 women, she is the most powerful. And I now invite Namrata to speak on management of LASIK complications. Dr. Namrata.
So thank you so much, sir, for that kind introduction. And I have changed the topic, the talk slightly, because I thought there might be some overlap. And I would like to congratulate Dr. T.P. Lane, Dr. Ragini, Dr. Preetham Samant, and everybody on the BOA and MOS for making this program so good and so successful. And of course, my young colleague, Dr. Karishma Wadia, for making me a part of this session. I would be talking to you about complications of LASIK surgery. Much has been talked about it. So I will just try to skip the parts which have already been talked about. Suffice it to say that the flap-related problems due to microkeratome are very few, less than 1% now with the current type of microkeratomes. And the videos, like Dr. Maipal said, are going to be old because this is what we used before 2003. But it is important to know if you're using one, what happens, so that you don't have to make that mistake and learn from it, but you learn from others' mistakes. So buttonhole flaps could be superficial or deep, such as seen here. And this may occur because of steep corneas, flat corneas, deep orbit, lack of synchronization between the translational keratome and oscillatory blade movement, and damaged blade. So whenever you have a thin, irregular or buttonhole flap, it is important that you defer surgery with the microkeratome, recut after 3 months, and some people like to do it early because they don't want subepithelial fibrosis to happen. Perhaps you can do it early if the refractive error allows you to do it. Now, this is a case of buttonhole flap, and ideally all such buttonhole flaps should be laid back onto their sides. And these marks which are present in the periphery do help a lot, because they help you to align at the submicroscopic level. Again, there's a buttonhole flap in the center, and this is a post-penetrating keratoplasty with a Z-shaped buttonhole flap because of a very steep cornea and a bleeding because of the presence of sutures. So they are best left aside, and then you plan a recut at a later date. Sometimes you can have epithelial ingrowth with the buttonhole flap, and in those cases you may, if the refractive error allows you, again just do a PRK, and so both the things are simultaneously taken care of. Then incomplete flap may occur because of microkeratome jamming, and there are various causes for it. So whenever you have an incomplete flap, it is important to know where the tear is. If it is in the periphery, then you can still go ahead with it. If it is in the mid-peripheral area or in the central area, reposit the flap back and recut at a larger diameter and at a greater depth for a microkeratome. So if it is 160, then 180 and 8.5, then 9.5. Of course, if it is 120, then 140. Now, just to give you one example, this is a torn hinge which is present at the periphery. So you can still go ahead with the laser. And in the post-operative period, one has to take care that from the area where the tear is present, there is no epithelial ingrowth, and such cases are more prone to DLK. So one has to keep a watch for that. And then you can have a dislodged flap, very beautifully shown by Dr. Mahipal sir also how to manage them. And these have to be addressed immediately. Then you can have eccentric cut like this. Again, you have to see where is your optic zone, whether your optic zone is less than the area where the cut is made. And if your optic zone allows, you can still go ahead with the laser. But if it does not, then you may have to plan a recut. Then you can have flat corneas and free caps, again, very nicely shown. If it is lost, then one allows central epithelialization. But if it is retrievable and it is greater than the optic zone, laser, reposit and go ahead. But if it is less than the optic zone, then again defer surgery. So this is just to show one case where free flap occurred and it is there in the microkeratome, and then you laser. An important thing is that because you've made these peripheral markings, you can realign the free cap, which was there after retrieving it from the microkeratome, into the place where it should be. And so it is very important to put these peripheral marks. Then these are our publications on outcomes of LASIK after flap complications. And then in RK cases, you can have the splitting of the RK wedges such as this. And again, one has to be careful so that you get the whole thing up without splitting them or losing the wedges, and then subsequently laser. Flap folds have already been dealt with, so I will not go into the details. They can be macro or micro folds, and only when they are visually debilitating do you manage them after reflotation of the flap, which can be done with hypotonic saline or with deionized water. And then, of course, you can have post-LASIK ectasia, which is a difficult problem to manage, but is managed with contact lenses, Intacs, CXL, and very severe cases, you may require a corneal transplant. Then you can have meibomian glands like this, fiber such as this, or epithelial defect. These are taken care of in the post-op period. What happens to the fiber that is there in the interface? This is just to show, and we published this over 1 year, it becomes a caricature of itself and actually just disappears away. Then you can have DLK, which can be there because of the meibomian secretions, blepharitis, epithelial defect, or debris or bacteria from the lids. And again, if you give topical steroids and topical antibiotics frequently, it does resolve. And sometimes it can be akin to a toxic keratopathy, which was also talked about. So you have to refloat. At times you can have an infection like this. Then you have to amputate this flap because the antibiotics won't go in. And of course, you need to scrape. And this is what happens after you have scraped and healing is occurred with a visual acuity of 660. And another case where the infection was so much that a corneal transplantation had to be done. Epithelial ingrowth again has been covered, so I will not skip the video just to show that if you do address it, it becomes absolutely clear after post-op 1 year, there is no recurrence at all. As far as the femtosecond laser is concerned, you can have an opaque bubble layer like this, and you can also have air bubbles there. And when you have air bubbles in the anterior chamber, then you have to put the tracker off and go ahead with the laser ablation after putting the flap back. Then subsequently, there can also be vertical gas breakthrough, such as this. As soon as it occurs in the initial part, it is best not to continue with this and plan the surgery at a later date. Then there can be a suction break like this. So here the femtosecond is initiated, suction break is there. So actually, ideally, you should not have, one should not have continued this. But if one does continue, then you have to replan the surgery at a later date. And if you look at the surface, it may appear to be a little corrugated because a previous cut has already occurred there. And although in this case, it did not make much of a difference, but this can affect your postoperative outcomes. And this is followed by placing of the bandage contact lens. This is just to show in the same case how you can have a peripheral spindle from the previous cut and the new cut. And this one video about complications of smile. In this, there can be various problems such as shown here. So the anterior part is being tackled with, the posterior part is being tackled with, and this is a false passage, in fact, which is being made. And when you have such a thing, then you have to abandon the procedure and plan the surgery at a later date. Then this is yet another case, and these are dark spots which are present in between, which again, there may be adhesions, micro adhesions or macro adhesions present if you have not dissected it properly. And with the help of the forceps, then this is being dissected. Then apart from this, again, this docking is not extremely good. And there may be either the lenticule can get stuck to the bed or it can get stuck to the roof. And then you have to decipher whether which plane you have entered. And sometimes you may have to take instrument of the help of the special instruments. This lenticule has got stuck to the back of the to your cap actually, and then you have to, with the help of the lamellar dissector, keep pulling it, and then subsequently the lenticule, it is ensured that the lenticule is completely out. We did do, with the help of the intraop OCT, rescue a lenticule which was very much there, and we couldn't make out where it is. So we took the patient on the IOCT to find out where it has got stuck, and we rescued, and we did publish this. And we again published this new technique of MIOCT guided smile. So to conclude, like, complications do occur with all kinds of refractive surgeries, including microkeratome, LASIK, and smile. But important thing is that you diagnose them timely, and you know how to manage them if and when you do happen to have them. Thank you very much for your kind attention.
Thank you, Namrata. I think Mahipal is not seen. So now I will request Anil Kulkarni sir is there.
Yes, sir is there.
Sir.
Yes, sir.
Any comment, sir?
And the problem is sometimes you get afraid of seeing the complications. But let's hope that, as said by Madam, that they are so rare that we really can proceed with the procedures. The point is, in a smaller setup like us, it's very difficult to manage because the expertise in managing the complications become less due to the paucity of complications. So this is a nice way of realizing that all these can be treated without any problem with the patient. Thank you, madam.
Namrata madam, one small question, Dr. Kudlu here.
Yeah, Kudlu.
Now, see, most of the center doesn't have this IOCT whenever you will have a very small retained lenticule. In such cases, can we stain the lenticule and still can we able to find out that lenticule where exactly it is adhering and can able to remove?
So I think people have described trypan blue staining. Then Dr. Mahipal's search group has described staining with triamcinolone. You know, you can pick it up with that also. So I think it is doable. And at the same time, if you don't have intraop OCT and if you do have an anterior segment OCT, you can take the patient from the table to see where it is at the AS OCT and then get the patient back and, you know, redo it.
Okay, ma'am. Thank you.
So actually a slit lamp examination, it doesn't matter that if you are not able to isolate even the slit, as you can see that you see on these eyes, that is very good. And triamcinolone also gives you something very, very this thing, and even at times just a hydration of the area will swell up the retained matter, and you can see that. So there are enough and more ways to see that. And what Amrita has said is very, very right, that a plain simple lenticule segment OCT done in the OPD setting will also give you as to whether there is a retained lenticule, what is the thickness and what is the extent. So, and then you can go back to the OR and remove that lenticule once you have either stained it or picked it up on the OCT. Okay. Any other questions or anything, or we can move on to the next speaker? Thank you, Namrata, for an excellent presentation. Is Dr. Ramamurthy there?
So, Dr. Ramamurthy, sir,
So Dr. Ramamurthy excuse himself because of the lockdown. Tomorrow he has some commitments and he needs to do them. So he has excused himself, sir.
Okay. So next we have, I think, Dr. Chitra.
Yeah.
Yes.
So Dr. Chitra, as you all know, is doing excellent work as chairman ARC, and she's the director at Eye Foundation and a great refractive surgery, and she'll be talking about what's new in laser vision correction. Dr. Chitra Ramamurthy.
Very good morning to one and all of you here. My very special thanks to Dr. Lahane and Dr. Ragdi to ensure that I was part of this very interesting program. And I'm amazed about the extraordinary potential of this team work which Ragini has with the help of her team, that within a week's time, she seems to have put together a great program for this weekend. So going on to my talk, what's new in laser vision correction? We all know that as far as refractive surgery is concerned, we've been always trying to reach out to the horizon, resetting different, what's happening? Sorry. Not able to.
It's not moving.
Yeah, I'll just stop, play it again and see.
Good morning, Dr. Keki, sir.
Good morning. How are you?
So then when we look at how the trend followed, there were different relations. Can you all see?
No, we cannot.
No, we are not seeing your slides.
How's that?
Share the screen.
I'll share again.
Yeah.
Very sorry. Can you see my slides now?
Madam, you will have to stop your screen.
Yes, ma'am, we can see the folder. We'll once you open it, we'll be.
Are you able to see now?
No, you'll have to stop your share screen and again share it, madam.
We can see the folder.
I don't know.
No.
It has never happened.
Have it on the desktop and
yeah,
then.
I have it.
Good morning, Ravindra sir. Good morning, Mahipal sir. Good morning, Partha sir. Once again, I have already said hi to Kudlu sir. Kulkarni sir, namaskar.
Namaste. So in 15 minutes, we will say good afternoon.
That's why I finished saying good morning before I start saying good afternoon.
Are you all able to see my slides?
No, you will have to open it, minimize, then stop share, and then open, minimize, and then do share again.
First open, put it on the desktop actually.
No, it's already there.
Good morning, Ravindra sir.
Yeah, yes.
Yeah. Good. Now just do full screen.
Can you see it now?
Yes.
Perfect.
Yes, ma'am, it's beautiful.
So these were the different ablation profiles which evolved over the time, we know, right from the plano scan days to the whole sequence of events which happened till where we stand today. I still clearly remember those days in 1997, wherein I would rely on an ultrasound biometry to get the thickness and look at the Tommy's topographer to look at the surface irregularity index or the surface asymmetry and the potential visual acuity, and look at the anterior surface float and go on with my treatment and feel happy. Then came in a way to do an aberrometry and measure the entire abrasions of the eye and then treat it on the corneal plane. However, although we could minimize the preoperative abrasions, we were not in a position to correct the abrasions which are being created during the treatment. And more importantly, it was not addressing the asphericity of the cornea. So then it sort of came to a point where you wonder that no matter how good you get, you always could get better, were the famous words of Tiger Woods. So then there was a new concept, a greater evolving understanding of refractive surgery, wherein it was realized that the spherical aberrations which are created during LASIK flap, which increases with a higher refractive error, if this could be addressed by giving in some additional pulse shots in the periphery, you're able to preserve the asphericity of the cornea, but then again, you have not been able to correct the pre-existent aberrations. Then in 2003, evolved the topo-guided treatment, which was a repair tool to treat all those disasters which were created in the process of learning flap creation. So how you could see on this particular map, how a steep area of the cornea is being regularized on a topographic mode, and thus the visual acuity is restored. But at that point, we seemed to needed to understand how was wavefront guided differing from a topo-guided treatment. In a wavefront guided treatment, in the process to create a planar wavefront, we found that you're needing to remove a lot more tissues. Whereas in a topo-guided treatment, you are actually shaving off those peaks of irregularity, and the flatter areas are being steepened by ablating around them, thus creating a more optimal corneal curvature, which is in fact a bimodal way of correcting a myopic and a hyperopic treatment. It seemed to make sense because when most of the aberrations seem to be on the corneal surface, on a topolizer, you are able to take measurements which are static, which are not changing as the wavefront guided aberrations would change with time. And so it became more reproducible, consistent, and you could collect a lot more peripheral data. So with this understanding, we also came to know that we are able to ensure that the asphericity of the cornea is retained. The treatment is centered on the corneal vertex, which seemed to be a better way to go than being centered on the pupil center. And the cyclotorsion compensation and the pupil centroid shift were all incorporated in the topo-guided treatment. So then, when you're doing so well with the irregular corneas, Alcon went to FDA to find out why could you not do the same treatment on a normal cornea. So before we plan on a treatment strategy, we needed to analyze the results, and this is what was done in myopia and myopic astigmatism. What was interesting to find was that at the end of 1 year, 90% of these patients had a 20/20 vision or better. More interestingly, 70% had 20/16 or better, and 30% had even 20/12 or better. And what was even more interesting was because you're removing those minuscule aberrations on the cornea, you are able to greatly address, and there was a significant reduction in glare halos, and then thus topo-guided treatment showed a very promising potential. Then it needed to compare this FDA treatment with the proponents of that time, Kanellopoulos and Lobanov, who were doing a huge numbers of topo-guided treatment. And what was seen in this map was till 20/20, they were nearly doing well. But when it came to 20/15, FDA seemed to be doing far better than what the other two proponents were doing. The reason was that in the FDA trial, they were being very selective, that they were choosing eyes which had minimal topographic abnormalities, where the manifest refraction or the clinical refraction and that measured by the topography were nearly same. In fact, the cylinders had to be less than 0.5 and the axis difference should be less than 10. So all these in reality is only met in 10 to 20% of the normal eyes. So Kanellopoulos thought that after all, the aberrations are largely created on the cornea. So if you do need to do a topo-guided treatment, you need to correct the entire cylinder, both in magnitude and axis, and ignore the clinical refraction, which is done. So, but then there were situations where the clinical refraction and that measured on the topography were very different. So would that justify that you treat more aberrations on the cornea, and would that be a safe way to go? So he went ahead, got the best of repeatable maps, looked at how the topography would look without the refraction being corrected, just the higher order aberrations alone being corrected, and then pull down the full cylinder, and then once the full cylinder and the axis are corrected, you need to compensate for the spherical equivalent which is created. So that is ensured that happens. That is the difference in the cylinder is half, and that gets added to the sphere, and thus an ablation profile was planned. So then again, you needed to compare. And when you compared, it was seen that they were doing pretty well up to 20/20 with the FDA treated eyes in near normal eyes. But at 20/15, they were flummoxed. So then it seemed reasonable to understand that you can't just do the entire cylinder on the corneal topography. You might have a perfect anterior cornea, but the posterior cornea would have its own cylinder astigmatism, which is contributing to it. We did our own study and found that 70% of our patients had an uncorrected vision of 20/20, 20% gained one line of vision, and there was 6% of them who had more than 0.5 diopter of residual astigmatism. So then we thought, why not we try that halfway mark, that is, use half the difference between the clinical refraction and the topographic refraction, and use the topographic axis and ensure that you look at the higher order aberration and adjust the treatment of the cylinder, and also compensate for the myopic or the hyperopic shift which could get induced. So if you look at this example, the topographic cylinder shows 1.63. and that which was clinically measured was 0.75. So you subtract it and the difference is 0.88. So you take half of this 0.88, that is 0.44, and add it to the clinical refraction, which becomes 1.19. So that is the cylinder with the same axis as 165 being corrected. But we need to deduct that amount from the sphere. So half of 0.44 is deducted, and then the treatment was planned. So essentially what we understood, that there was a lot of analysis and mathematical approach which was mandated, and you could not predict what was the contribution of changing the topographic features. And there were contributions of the posterior cornea and lens, and that is what which explained the difference between the clinical refraction and the topographic axis. And this is where Lobanov came out with his concept that if you are doing a resurfacing or regularizing of the topography, you need to keep in view the refraction on the anterior surface of the cornea, the astigmatism, the posterior surface of the cornea, the lenticular astigmatism, and the amount of deformity which is created by the abrasions on the corneal surface, and then plan, analyze the treatment based on lens theory and optical physics, and then come to the final correction. Now here you can see there were two areas of ptalysis or difference in heights on the topography, which was so different, which could explain why there was so much difference in the clinical and the measured refraction. And if we needed to incorporate this higher order aberrations and go ahead and do a vector analysis and find out what is that final component of astigmatism and the sphere adjustment which has to be corrected. So based on this, like in this particular case, he just converted all to zero and just looked at how much is the aberrations being corrected on the corneal surface, and then went ahead and decided that this kind of correcting a hyperopic ablation in the mid-periphery, what would be the spherical impact of this, and incorporating this and doing a vector analysis on an analytical software, which would decide the final correction. So after all this mathematical jargon which I discussed, what was found in this 34 eyes, that in 60% of the cases, the Phocides did better. 30% of the cases did as well as the wavefront optimized or the contura vision, whereas in 10%, the wavefront optimized did better. It also mandated that you compare it with the FDA results. And what was most amazing was, if you can see, that the Phocides did as well as the FDA. Remember, FDA was being done only for near normal eyes. So we went ahead in our center and analyzed 60 eyes of 30 patients with a significant amount of sphere and cylinder, and then saw them over a period of 3 months. The analytical software in the machine did the vector analysis, and we found that at every aspect measured, the uncorrected vision, the best corrected vision, the total induced astigmatism, and all the aberrations, Phocides results compared with the contura. So keeping in mind that this is the way to go, I wouldn't say that we're still at the end of the road. What is most important, that we continue to analyze our results, continue to ensure that we do not compromise on the uncorrected vision, do not end up with losing lines. But tell me, friends, we've had LASIK doing so well, we've had PRK doing extremely well, the topo-guided treatment and SMILE. So the ship is already in the harbor, it's quite safe. But then we also need to understand that's not what the ships were actually built for. So we need to be on this excursion of constantly improving ourselves. Thank you.
I think thank you very much, Chitra. It was I think it was a too good presentation, and what you said about the ship is true. Thank you very much. As you know, the Chitra is a ARC chairman and very powerful woman in India in AIOS, and my sister. Thank you, Chitra. Thank you very much. So now
I think
we are.
Hanji, Dr. Lahane, go ahead. Continue.
Yeah. You can. Yeah. No, you can now invite another speaker, sir.
Okay. Thank you very much, Dr. Chitra. We'll go on to the next speaker. I think it is Kudlu.
Yes, sir.
Yeah. So Dr. Kudlu, as we all know, is such a nice individual and has done excellent work in refractive, one of the pioneers in smile surgery also. And he's doing great work in Karnataka, and also doing a lot of camps and charity work also. So over to Dr. Kudlu, who will be talking about presbyopia, still unconquered territory. This is his forte, and he's doing a lot of cases with presbyon. So over to Dr. Kudlu, please.
Thank you so much,
Thank
sir.
you. Thank you, Maipal. Thank you, Keki. Kudlu is my best friend, and I think he is really doing a very good charity work. And I think I must salute him for his charity work. Kudlu, go ahead.
Thank you, Maipal sir. Thank you, Lahane sir. Thank you, Ragini madam, and also Preetham for this wonderful meeting. Also, I always feel very happy to be always part of BOA. So my talk today, I'll be talking about presbyopia. I've been doing since last 8 years. This is my financial disclosure. I'm consultant to Carl Zeiss India. So presbyopia is a physiological progressive loss of accommodation affecting individual in their middle age, regardless of any underlying refractive error, causing difficulty in sharply focusing for the near vision. So these are different principles to correct presbyopia. You can either go for monovision by correcting one eye for distance and other eye for near, or you can even opt for multifocality either with the lens options or even in the laser platform, or you can even think about increased depth of focus, what we do it in inlays. So these are the few options. Those who are really wondering what is this pharmacological option, one of my friend from Colombia, he has done in around 1,000 plus patients using something called FOETS with some parasympathetic mimetic drugs that will help in for near vision. Of course, spectacle being the most popular, I think everybody uses. Even some of my friends even uses contact lens for presbyopia treatment. My mainstay for today talk is surgical treatment. So these are the options. If you coming to the lens procedure, multifocal intraocular lens, a lot of us been doing now trifocal IOLs also in the market with even EDOF lenses. Coming to the corneal procedure, 3 of the procedures are very popular: Presby LASIK, Presby Max, Presby Bond, and even few of my friends also doing this Supra core. Oh, and other procedures like scleroscleral modification, like by implanting sclerospacing device, or even you can opt for laser procedure. So coming to the multifocal IOLs, I think most of us know the most popular one is a diffractive multifocal IOL. Now patients with the astigmatism, you have got options of going with the toric multifocal intraocular lens. Now, I think last couple of years, most of us has been shifting towards trifocal intraocular lens because of the advantage of intermediate vision. Even some percentage of our friends still using extended range of vision IOL just because of the less glare and halos during the night time. Accommodating IOLs almost vanished from the market because of its price and in difficulty in implanting. And just 1 or 2 words about this phakic intraocular lens with multifocality. One of the Indian lens has come out with this. Some people are getting better results with this. Even patient already underwent pseudophakic, both the pseudophakic. You have got an option even thinking about putting a circleplex pseudophakic lenses. So coming to the cornea inlays, I was very happy to hear from Dr. Amar that he was telling that he's the first person to implant this camera inlays. Normally what we do, we implant this camera inlays in the non-dominant eye which increases the depth of focus similar to the pinhole. Like you have to do the, like how you do the LASIK flap, it has to be inserted under the stromal pocket. These are the other couple of inlays, presbya and revision optics, which is not so popular, not also FDA approved. These are the problems with cornea inlays. Definitely there will be reduction in the distance vision in the non-dominant eye, some amount of glare and halos with some reduction in the contrast sensitivity. Those who are really don't know about this scleral cilia complex modification, I just want to tell you, this is something complicated procedure where we have to put 4 PMMA segment which is implanted under the sclera by making 4 incision in the sclera. And what they say that after implantation of these segments, sclera is supposed to be lifted to create more space between the ciliary muscle and the crystalline lens, thus have a presbyopic effect. One of my friends from Taiwan, he is very popular in especially this laser S procedure. What he does, by applying a visual light erbium YAG laser that ablate around 600 micron laser spots in the sclera, which presume to free the ciliary muscle to contract normally. Normally they'll have a near vision effect of around 1.5 diopters. So coming to the laser procedure, I think Presby Max or Presby LASIK, basically both the treatments are quite similar. Basically it's a multifocal LASIK treatment. By aspheric treatment, it induces spherical aberration for depth of field. But there are problems with Presby LASIK. Few of my friends been doing that before, now they stopped because of initial compromise in the distance vision, at least till 3 months. A lot of patients complaining of adaptation problem because of the multifocality. Even some patients complaining of night vision problem, and basically it's a pupil size dependent procedure. Coming to the Supra core, a couple of my friends in India, they are doing this procedure. Once again, it's a pupil dependent LASIK procedure done on the Technolas Bausch & Lomb platform. Unlike the monovision, what they do here, one eye is treated for the distance and other eye treated for a near. No, here the procedure, it treats both the eyes for distance and also for near. So the procedure in Supra core is, it makes use of central near peripheral distance concept, wherein during the natural accommodation, when the eye focuses on the near objects, the pupil constrict and the eye looks through the near add addition. But when the eye is looking at distance, the pupil dilates and allows the peripheral rays to pass through the aspheric optimized what we have created in the periphery to improve the distance vision. But predominantly, it's once again, it's a hyperopic treatment. Hyperopic patients do really well, and it need to be, you require a refinement. Also, a lot of patients coming for retreatment. Let me come to the presbyon. This treatment I've been doing last 8 years. Basically, whatever the refractive procedure, refraction is very important. Then as a doctor, I myself check the dominant eye testing. Then I myself test for micromonovision testing. This is very important. If you do this couple of tests yourself, then you are through with the procedure. Then remaining all same, like what you have to do in the LASIK evaluation. The whole planning will be done with the help of CRS master, which is given by the company, and the treatment can be performed either with their MEL 80 or MEL 90 platform. This is the basic mechanism. One is monovision principle, depth of field to reduce anisometropia, spherical aberration control, vertex centration of spherical aberration, multifocality from epithelial lenticule, retinal image processing, neural summation, blur adaptation, and neural suppression. So what exactly we do? We make the dominant eye emmetropic and make the non-dominant eye myopic by 1.5 diopters. Along with, we also create a controlled spherical aberration in both the corneas. By doing that, we normally have something called blend zone, where the vision from the distance and the vision from the near, it joins and there is binocularity retains. So why we pick this micromonovision? Because you have seen in children with amblyopia, brain tend to suppress certain blur from the one eye to the other eye. So basically you have to treat, even though the both eye vision is 6/6, you have to treat both eyes. It's a bilateral approach. And the one more thing, these are my results from last 2 years. I have done, I think, more than 500 patients, but these are the 300 patients actually come for 2 years follow-up. What you can see here, none of the eyes lost more than half Snellen's line of vision when compared to the pre-op corrected distance visual acuity. This is very important for me. And the advantage of this treatment, it is not depend upon the pupil size. Even you can stretch in my case, I have done for hypermetropia up to 5 diopters, myopia up to 8.5 diopter, depending upon the Pachy value, even astigmatism up to 3 diopter. All my patients had a very good intermediate and near vision. In 97% of the patient, as Dan Reinston, my friend Dan Reinston say that 97% of the patient tolerate this treatment. Just I'll end half a minute. I will take a couple of case series. I just want for beginners for laser procedure. This is a patient with a 38 years IT professional with a normal topography with myopia, right eye around 3.25 and left eye around 2.5. Patient wanted a spectacle free vision because he's a known swimmer. Then in this, what we did, we explain him about that he has already started developing a near vision. We just gave 1.25. Then we gone into the press band with reducing from 1.5 to 1.25. Patient is doing really well. Coming to the second case, 46 years old female bank employee, hypermetropic, near acceptance is 1.5. Once again, we gone ahead with the patient wants to spectacle free vision, and we gone in this patient. One thing I want to tell you, all hypermetropic patients, do not forget to do a cycloplegic refraction. When you do the cycloplegic refraction, definitely there is a high amount of refractive error. Then you can give a near vision for 1.5 diopters and you can go ahead with the treatment. The case 3, very important, I have done in a patient with a jeweler. So simple myopia, 0.5 diopter, left eye 0.75. In the option 1, I just gave it a near vision 1.5, but patient cannot see even near small objects. Then I increased to 1.75, patient started doing well. I went ahead with the option 2. The last case, the Navy officer, right eye -2, left eye -3 diopters. Patient wants to be free from the distance vision, not aware of presbyopia symptom. In such cases also, you have to do the repeat refraction, make the patient to read fine prints with the distance vision, make him to aware of presbyopia, do a monovision trial with the 1.5, and we gone ahead with the presbyon. So in the end, what is the best option? Okay, if you think about multifocal intraocular lens, corneal inlays, Presbymax, or supracore, presbyon. Okay, as far as the distance vision, intermediate vision, near vision, night driving problem, contrast sensitivity, if you think about adaptation safety wise, probably I think presbyon is definitely the best option till today available in the market. Once again, I thank Lahane sir. I wish him best of luck for his coming elections. And once again, I thank the whole BOA team for this wonderful opportunity. Thank you, one and all.
Thank you very much, Dr. Kudlu. Great talk. I think we are running behind schedule, so we'll go on to the next speaker. In case anybody has any quick comment, they can do that. But let's go on to Dr. M.S. Ravindra. Again, a very nice and a thorough gentleman, great practitioner of SICS and also refractive surgery, and my senior from RP Center. Over to you, Dr. Ravindra. You will be talking about hyperopia laser vision correction.
Thanks, Dr. Mahipal. Hope you can see my slide.
Yes.
Okay. I am always indebted to Dr. Ragini, Professor Lahane, and Dr. Preetham, Dr. Swapnesh, and all the office bearers of MOS and BOA for giving me this opportunity to be with the stars, luminaries of our country in the field of LASIK. I have no financial interest, but I do use all the gadgets that I mentioned. Hyperopes. Most of the LASIK surgeons are worried about hyperopes and worried about regression. This person is not going to be happy for some reason. But then let me share my experience and thoughts about how to be happy yourself and how to make the patients really happy with hyperopic refraction. In my opinion, hyperopes, especially when they are 30s and 40s, are much more happier than a myope because they would have gained not only distance vision but also near vision. As Dr. Kudlu said, cycloplegic refraction is a must, not only for hyperopes, for everybody. We routinely check the binocular vision, especially if it is hyperopic patient. Look at the amblyopic status. Look at the fovea. Is it a steady foveal fixation? Even if the vision is 6.6, the plus or minus, this is very important to check whether the foveal fixation is all right. And mesopic pupil size is important in all of them, especially in hyperopes, because you're going to have a larger optical zones. Angle kappa is extremely important again, and rest of it is similar to myopia. And we use this platform which gives us the ready-made software to treat +6 spherical, plus in addition to it, you can treat as much as +6 cylinders. This is the platform we have, and we have treated up to +9. I'll show you a couple of cases. And I love ASA, and we have all these facilities. But to make those who are using alcohol, to make it absolutely painless, I would suggest these tiny flaps in the edge of it. If you excise all of them at the end of the surgery, at the end of your LASIK, remove them so that the epithelium that's left behind is tight and nice, just like you do a transepithelial or epitome removal. Patient will not have pain. It's not the alcohol that's causing pain, but these little flaps which move under contact lens are the cause for pain. And now we remove all these, trim them up, and there's no pain, even if you do it under this thing. What's the most important thing is the cyclotorsion, which can be avoided by encouraging the patient to open both the eyes. Of course, cyclotorsion facilities are available, but then if you put a drape there and this eye is closed, drape is going to touch his lashes and he keeps on blinking and he tries to close the one eye. So that can be avoided by putting a shield and do the fixation of the eye. The face has to be parallel. All that has to be done before you drape, because once you drape, you don't know what's the position. And after doing that, do not move your movements. If there is a decentration, move the head and bring him back. So that way you are sure that the face is absolutely parallel to the face and in axis. Do not move the joystick after you have initially looked at it. This is one of the very important things to find out that you're doing the proper centration. We do a thin flap technique. This is especially important because often the flap size is 9.5 in hyperobes because they are larger. And how much of downward pressure, see, that's a microkeratomy, you apply downwards. And the classical teaching is you apply too much, that if you apply too much pressure, more of cornea prolapses into the ring here, and you're going to cut thick flaps. So you can have a uniplanar flaps even with this. The secret is just touch it 360 degrees, it touches the limbus and activate the vacuum, and then you will have a very little amount of cornea prolapsing into it, and you'll have a nice uniplanar flap even with a microkeratome. And the next thing that is a must in hyperope, this is the most important thing. There are a lot of anatomical points on the cornea, and the laser can only see your pupil, whatever the size of it, and it can start ablating around the center of the pupil. But is the center of pupil is the place where you have to ablate? I'll tell you that's the typical hyperopic eye. All hyperopes, remember that they have pseudoexotropia. What does it mean? They're not using the pupil center, they're using a point nasal to pupil center to see the world. This is very important. If you're ablating, leaving all the statistics, all the criteria, all the nomograms to the machine, it will be treating eccentrically to the visual axis. This is something which you'll have to do to have excellent results in hyperopia, because hyperopia is not correct in the center. You're correct in the periphery, and you will have an indirect effect on the center. This is very important in hyperopes. And all of them have. Look at this eye. That is where the machine starts treating, but that's a visual axis depending upon Purkinje 1. The closest to visual axis is Purkinje 1 image, and you are supposed to ablate it around that and not this. About 95% of all the patients have visual axis elsewhere than the pupil. Very few people have it, and you can see this eye. Whatever calculations you make, you'll have to actually assess it. Ask the patient to open both the eyes. Look at the green blinking light. You can see here, it's no more here. That's a pupil size you have at that point of time. You'll have to shift to the right side. That's a plus x-axis by about 200 microns as you assess here. So this is the most important thing. That is the ablation. That's a cornea. That's a visual axis. That's a pupil. Left to machine, it is going to treat there. Now you'll have to shift it up there to the left side to have a perfect results. As you can see, I shift that to this. This can be done in every machine, has got a different way of doing it. And see, the pentacam gives a rough estimate. This is the distance between pupil center and vertex, not this is not angle kappa, but this is nearest to angle kappa, 0.35, and minus and this is important, minus and plus. What does this minus and plus do? Yeah, this is how you see the right eye and left eye. I mean, when you are looking at it, forget about the patient is lying down, forget about which eye is it. Any movement from the center to the right side is an X plus. Any movement to the left side is an X minus. Any movement towards you, you are sitting here, is a Y minus. Any movement up towards the patient's leg is Y, whether it's right eye and left eye. So minus 0.35 means it's on the X axis. You'll have to shift the fixation, the visual axis pointer to the left side by 350 microns, and you'll have to shift Y axis downwards here by 190 microns. This is in millimeters. So this is a must in hyperopes. And after doing that, this is again the patient has to blink and look at the green light all along. And you do the center test. The center test confirms that the center of ablation comes from the center of pupil and rests on this. So confirm it by doing the center test on the machine. And that's what you have to, this machine says x-axis plus 1.75, that you'll have to shift the centration to the right side. It's on the plus side, to the right side. And 150 microns is what I've taken. And then you start ablating. Then you'll have a perfect, very good results. And you know that the optical zone that we're going to keep in hyperopes is larger. It's not 5.5 and 6. Generally, I keep 7 millimeters. And then there's a blending zone. So total ablation becomes about 9 millimeters. So you'll have to have routinely a 9.5 millimeter flap. And if you're going to treat that, this is a flap that you kept that. If you're going to treat this, hyperopic ablation is in the periphery, that's going to hit the corneal flap. So if you do not protect the corneal flap, there'll be an ablation here, there'll be an ablation here. Post-operatively, he'll have a gutter-like thing because there is a double ablation here. What you should do is you have to protect the flap on this side so that the laser doesn't hit on this side. What I do is routinely looking at the parameters, the flap making itself, I decenter towards the nasal side. I routinely do it about 0.5 millimeter or even 1 millimeter. So flap itself is decentered towards the nasal side. So to protect the hinge, and you will have maximum ablation on this side. So imagine if you're going to protect with this hinge, that means this area, that area is not ablated at all. So shift the flap itself. I create a large and eccentric flap depending upon the size of the cornea, and that will serve a lot of the flap itself is moved that side. So let me go fast. And again, the machine can say something. The pentacam can say there is a decentration of 0.51 in the right eye and in the right eye here from the pupil center, but actually you'll have to reassess the amount of decentration you'll have to do actually on the table. That can be done. Every machine has got the facilities. And the next one is you are going to tell the patient to look at the green light continuously throughout the surgery. Tracker is there, but if the patient is moving his eye left and right and up and down, and the centration will not be proper. So we, in the last 200 eyes, we did 188, we did the decentration like this. It can be small, y-axis 20 and 160. This is not dependent upon the pentacam results. This is dependent upon the actual measurements that you do on the table. Only 12 eyes did not need a decentration. And imagine you have patient with that kind of power, all the parameters are applicable. You have a 7.75, 2.5. How do we manage it? If other parameters are good enough, and look at how much will be the corneal steepness at the end of procedure, what we do is we correct +6 and full astigmatism in first go, and treatment 2 is also fed into the machine, and residual hyperopia, that's 1.75, I'll treat it again in the same sitting. K readings and PACI for the second treatment has to be modified, because after the first treatment, both the K reading and the PACI would have changed, and you'll have to refocus the corneal surface for the second, and presumed post first treatment values are entered in the second treatment. Optic zone, ablation zone, and same amount of decentration is done for the second treatment also. As you can see here, these are the parameters. Optical zone, I've kept it at 650. Decentration is 300 microns on to my left side, 100 microns towards me, the surgeon. So that's the second treatment parameters and first treatment parameters. And we have done many cases using these parameters with excellent results. And it is possible to treat more than what the machine offers us in some special situations. How much of K? It is not one diopter treating corrects one diopter of K reading. We have calculated that one diopter of correction of the the refractive error in the hyperopic zone corrects about 0.6 diopters. So when you modify the K reading for second treatment, that's the data you'll have to use. So that's the result of double LASIK treatment in the same sitting. Every person is not fit for it, but you'll have to have a flat cornea, you'll have to have a normal size, thickness. The hyperopia doesn't treat the center, it treats the periphery. So you're all right about central corneal thickness. The presbyLASIK, Dr. Kudlu has covered it. I'll not cover much of it. I'll use the FCAT program that's in our this thing. Basically, what we're going to do is we're going to change the asphericity from pre-existing 0.31 to -1. -1 asphericity will give an extended depth of field. We use ASIS sphere adjustment nomogram to custom Q value. We can also do, this is what is the Q target. So the patients are extremely happy. We have done monovision treatment also. The dominant eye is done for distance, and the non-dominant eye, we have corrected the presbyLASIK. They are also, we'll have to talk to the patient. Counseling is very important. See here, the right eye pre-LASIK, the patient had a Q value of 0.15 on the minus side. It became -1 post-operatively with very good near vision. And the other eye is optimized treatment where the Q value was not adjusted. He has very good distance vision in that. So we did about, I analyzed about 76 consecutive eyes, no intraoperative or postoperative or long-term complications. And this is the most important thing I would like to do. If you have done a cycloplegic refraction, if you have done the calculations well, and if you have kept the optic zone larger, the regression is almost nil. We had no regression in last 27 cases, and 41 hyperopes with presbyopia were treated by this technique out of so many eyes. That's average Q value preoperatively and postoperatively. And we use 58 microcutomes, 13 femto, and 4 of them were ASA, and 1 was transepithelial treatment with ASA. So decentration was done in a large amount of patients. In hyperopia, every patient had decentrations. One of them had a decentration of 1,250 microns. That's 1.25 microns was the decentration needed in one of the eyes. And optic zone was 7 millimeters. Some of them are 6 millimeters. And vision after 4 years, there is no regression. 4 years follow-up was the longest follow-up. It was one of the patient. And this patient had 6 and 6 vision even after 4 years. That is surface ablation. Surface ablation is talked not much these days with the various facilities. So this is the person 4 years post-op, absolutely clear cornea, and vision is great. And even on densitometry on this haze evaluation, there's hardly any haze in these patients. So hyperopic LVC is extremely good. These are the points I would like to stress upon again. Do a good cycloplegic refraction. It does not matter even if you give some myopic correction in the immediate post-op, but do not undercorrect these people. Otherwise, they'll come back again. Large decentered flaps are important, and it corrects a lot of them. Thin flap technique is, I use it because then we have to have a large flaps. Optical zones have to be larger to minimize the aberrations. Angle kappa management is one of the most important thing that we have. Thank you.
Thank you very much, Dr. Ravindra. Any quick final comments, because I think we have overshot the time significantly. For me, it was a great session of learning and covered a lot of aspects of laser vision correction. Dr. Lahane or Kudlu, Ravindra, Dr. Chitra, Partha, Preetham, anybody, Aditya, Dr. Kulkarni, anybody wants to make any final comments?
I think, sir, the last session in which we covered the presbyopic part of the laser vision correction was a very, very important part because it's an unexplored part by most of the thoracic surgeons. And, as the nomograms, as the scientific advancements take place, I think we should have more elaborate sessions on this with clear-cut directions for those who are not using and how to get onto that, and the detailed workup which it entails.
Also, one important thing is the latent hyperopia which is there in the hyperopic patients. As they come closer to 40, some of this latent hyperopia gets unraveled, and we need to understand that, and that is not the cause for regression.
So I'll just wish to put in my thought process, as was pointed out by Krishna Prasad. I think if I have to put my money on something, I feel it will be a lens-based procedure that will ultimately come out winner rather than a cornea-based procedure for correction of presbyopia. That's my hunch, because the speed at which the intraocular lens technology has improved over the last 5-7 years with the coming in of the trifocal and the combination with the EDOF, etc. And if the dysphotopsias go back, because the chances of regression or anything, etc., is not there in lens-based surgery. So my personal preference would be possibly on a lens-based surgery rather than a cornea-based surgery for patients with presbyopia, specifically patients with hyperopia with presbyopia. That's my take on it.
So we give the options, in my practice, all the options give. So in the end, whatever patient selects, of course, we also do a lot of multifocal, trifocal, or even EDOF combination. But younger patient, the patient is, if he is around 40 to 45, that patients normally I pick up them for laser-based procedures.
Yeah, I agree. And the other thing is that we are still not looking at dysfunctional lens syndrome, which these devices like iTrace picks it up very well, that there could be dysfunctional lens syndrome where the patient's quality of vision actually goes down and not the quantity. So anyway, these are presbyopia still remains a unconquered kind of thing. I think where a lot of work is being done. Once we conquer presbyopia, I think that will be a large chunk of people that will be satisfying. Thank you very much, Dr. Lahane sir. Thank you very much, Dr. Ragini.
Thank you, Dr. Maipal. Thank you, Namrata. Thank you, everybody.